Hey friends, welcome to another Transforming Chaplaincy webinar. It's great to have you here among us, and thanks for your choice to spend some time with us. Today, you are in for a treat. Just want to share some introductory slides as we get going here. So again, officially welcome to Fatalism and Self-Efficacy, the role of psychosocial factors, religion, and spirituality on population health. Hope you can join us in 2 weeks to celebrate Spiritual Care, Pastoral Care Week among us. We are delighted to have one of our Research Network conveners, Angelika Zolfrank, join us, as well as her colleague in her setting out on the East Coast, Dr. Brandon Unruh, psychiatrist in her setting. They're going to be talking about mental health clinical pastoral education, a specialized CPE program, and that's based on a recent manuscript that Angelika had published. So please track that down. I believe it is open access, but if you want to join us, there's the QR code for that. Please keep your smartphones out. We'd love to have you consider joining us for this event. If you haven't registered yet for the Healthcare Chaplaincy State of the Science online version, we'd love to have you be there on October 30th. And just to say, if you sign up now, friends, no Ginsu knife, but we'll be sending you 6 research CEUs to join us. So that more than fills the cup, as you know, if you are a board certified chaplain. So it'd be great to have you among us for that event, as we recap those important papers and findings for our field. So love to have also you consider joining us for, this is my PhD work as I'm kind of rapping hard to get my dissertation going. But if you're interested in the clinical notes that we do as chaplains, please join us for an evidence-based curriculum that's happening next month, Tuesday, November 18th, and there's a QR code for that. I would invite you to consider joining. It filled up pretty fast last time we offered it in May. If you're we appreciate you being part of Transforming Chaplaincy. If you are considering what it might mean to sports in other ways, there's a way for you to share resources with us, and we appreciate that consideration. Without further ado, it is my pleasure to also introduce another one of our Research Network conveners, Dr. Chuck Valenci-Hein. Chuck, in addition to being one of our co-conveners, as you can see there, the third bullet point with the Population Health and Digital Spiritual Care Research Group. He serves as the chaplain specialist with Ascension on the on-demand spiritual care team, and he is quite interested in what it means to work on this spiritual care in an ambulatory and population health context. Chuck, please take it away.
Thank you very much, Paul, and it is great to be with you. And it is that work within the ambulatory and population health context that first allowed me to cross paths with our presenters today. In some ways, they really should be introduced together because they stand together at a very unique intersection in healthcare and spiritual care. Having extraordinary expertise on the clinical side, but the research side, obviously, by their vitas, you can see how much work they've done. A deep concern for the social determinants of health, and especially for those who are at highest risk within our healthcare system. Dr. Ageti and Dr. Walker served together at the University of Buffalo Jacobs School of Medicine and Biomedical Sciences. You can flip, Paul. As handsome as that picture is, this one's even better. Dr. Ageti, general internist and health services researcher with over 500 peer-reviewed manuscripts. And again, I think one of the most amazing things about him is with incredible expertise in research, he has always maintained a clinical perspective, and especially those concerns relating to women, ethnic minorities, both in terms of healthcare, but also as a mentor in growing investigators, researchers, and academics from those populations to serve in the world yet to come. One of his chief partners in crime has been, and next slide, Dr. Rebecca Walker. I don't know where else it would seem like, oh, that's all. My count was about 200 published articles. And she is the associate professor for medicine and the division chief for the Division of Population Health there at the Jacobs School in Buffalo, with again research that focuses on healthcare disparities. Their topic for today, oh, I'm sorry, I've got two presenters that were all respondents who should be familiar to our Transforming Chaplaincy folks, Dr. Gila Raji, who is one of the former fellows within our Transforming Chaplaincy program, has gone on to a PhD and now serving on the faculty at the University of Michigan School of Public Health, research that focuses on primary prevention, spiritual distress, and the role of chaplains. And our second responder is Dr. Kelsey White, again, no stranger to us at Transforming Chaplaincy, one of our research fellow alumna, now working at Virginia Commonwealth University and also the editor-in-chief for the Journal of Healthcare Chaplaincy. So with that, I want to turn things over. The topic, fatalism and self-efficacy, the role of psychosocial factors, religion, and spirituality in population health. Dr. Getty, Dr. Walker, I'm so pleased to have you here with us.
All right. I think we are both excited to be here, and I'm just going to share. We're going to do a joint presentation. I'm just going to start off with just going through and making sure that our slides are visible. Everybody can see our slides. And then I think Dr. Walker is going to go first. So our topic is fatalism and self-efficacy, the role of psychosocial factors, religion, and spirituality on population health. And we're going to touch primarily on the burden of chronic disease, some overview of psychosocial factors and health, and then we'll touch on religious and spiritual coping, and then fatalism and self-efficacy. But then we have some, at least I have some thought-provoking questions about what the next steps will really look like. So I'm really excited to hear have us have a dialogue about that. So Dr. Walker will go first, and I'll just advance the slide, Rebecca.
All right. Well, so just to give everyone some grounding in chronic disease, we wanted to give some information from a population health standpoint of the burden of disease. So in the US, chronic disease is the leading cause of illness, death, and disability, which often is not super shocking for the US standpoint, but this is actually also true worldwide. So we've seen a major shift where infectious diseases used to be the leading cause of disability and death, but it is really switching over across the world to chronic diseases. In the US also, 8 of the top 10 causes of death are actually chronic diseases. So 6 in 10 adults in the US have at least one chronic disease, and 4 in 10 have 2 or more. So you can imagine this is quite a large burden if you're talking about more than half of the population having at least one chronic disease. The pure definition of chronic disease is something that is going to last longer than a year or is going to impact individuals' activities of daily living. So these are major impacts on individuals' daily life. They have to make changes in a lot of their self-care behaviors like diet, activities that they engage in, and physical activity. And Dr. Good, if you want to go to the next slide. What we have here is listed the leading chronic diseases, just so that you have a sense of what those would entail. So within the US, we have 42% of the adult population indicating being overweight or obese, 31.6% having hypertension, which would be high blood pressure, 12.5% having diabetes. This is both type 1 and type 2 diabetes. 11% with asthma, 8.2% with kidney disease. That includes individuals who are on dialysis, 6% having a depressive disorder, 3.7% with a COPD, and then 0.4% with cancer. So looking down through these, you can see these would be the type of diseases that we're talking about when we're indicating chronic disease. And you can see, first of all, the large burden that it has on the population, but also the wide range of diseases that this includes. And then one more slide, just to give you a sense of the overall economic burden. Chronic disease is the leading driver of the nation's healthcare costs. So right now, the estimates are at that we spend 4.9 trillion annually in healthcare. It's not a small number. You can see on the left-hand side, this is a recent breakdown by the AMA of how healthcare costs are spent. So you can see that large purple portion that is hospital care, then physician services. Another large section, the blue, would be other personal health care. So this would be things like home health care. And so these are large amounts of the overall US healthcare spending that are going to be impacted by these chronic diseases.
All right, so now my turn to just talk a little bit about religion and spirituality and just kind of some grounding. For most of you, this is pretty much basic stuff, but I just thought it was worthwhile to kind of bring this into the picture. So I think for most clinicians, the question has always been, what's the difference between religion and spirituality, and how does this really overlap? And so we always try to I found this slide to be helpful, but then also just the idea that religion is a search for significance or cause within the context of established institutions that's designed to facilitate spirituality, whereas spirituality is an aspect of humanity through which individuals seek ultimate meaning, purpose, and transcendence. And so the idea is really, as people think about this, because many times they're used interchangeably, at least in the clinical environment, and it's really important to understand some of the background. And then in terms of what's been known, from when I was a resident way back in the day, we've always had this idea that there was some kind of important, that religion and spirituality are important in health. And there's a body of research has found positive association between religious and spiritual involvement and health. And things like better mental and physical health outcomes, improved adherence to medication and self-care behaviors, better quality of life, lower depression for individuals with diabetes. So there's a body of work that's been around, and I think a part of the conversation has always been, the breadth of research, the strength of the research, and what has been done. I think the research has gotten stronger as the years have gone by. And so this is another slide that I find helpful as I talk to trainees and residents and fellows in terms of just the biological, psychological, social, and spiritual. And these all domains are actually important because I think most clinical people are very, very comfortable with the biological mechanism. And so you think about biology, and then more and more now we're beginning to, psychological, I think, has gotten more traction. In more recent times, social factors have actually begun to take preeminence with social risk, social determinants of health. But now, I think one area that sometimes gets left out in some of those conversations is the spiritual component, and how does that play? How do beliefs, rituals, how do all of these factors affect health, and what is the relationship? How do spiritual factors impact psychological factors? How do they then interact with social factors? And that all of these things are actually interrelated. And then I just want to now dive into, this is the area where we have done a lot of work, and that is the concept of coping, and that religion and spirituality as coping strategies, especially for individuals with chronic disease. And we've shown, and others have shown, that religion and spirituality are two of the most important social resources to which people turn to cope with chronic disease. So when people are sick and they have chronic illness, a lot of times they will turn, and there are several modes through which this may occur. Some of it may be obtaining social and emotional support through religious organizations. Others use religious beliefs to enhance sense of control over health outcomes. And then others attribute control of their health to a relationship with God or other higher being, so they're better able to manage. So each of these different approaches allow people to cope with chronic disease. And more and more, I think the work of Polzer and Miles actually showed that there are two types of coping approaches: a collaborative pattern, which emphasizes God as supporting in the background, and the individual is primarily responsible for their self-management of disease. And with this approach, there's this dynamic relationship. So if you take diabetes, for example, there's this relationship where the person with diabetes actually sees them working hand in hand with God to actually get their diabetes managed, as opposed to a different approach, which is more of a submissive pattern, where God is at the forefront and being primarily responsible for the condition. The emphasis is placed around conditions of faith. And what we find in some of these individuals who use this coping strategy is there's a deference to God and a sense of whatever is happening, I really don't have much to do. And so they take a less collaborative approach, and they're more almost waiting for something to happen. And so you hear people talking about miracles happening, and this needs to happen. And so that pattern actually has sometimes is helpful, but we've actually found in our research that sometimes this approach may impact people's ability to manage disease. And so a submissive pattern can, and it doesn't always do that, but can shift responsibility from the individual to God or a higher power. It could weaken the individual's resolve to take ownership of chronic disease, may even impact self-care behaviors, and can lead to poor health outcomes. And these types of interactions then play out in clinical encounters where you're having conversations with patients, and you actually begin to have conversations where people are saying, well, I defer, and there's really not much I can do, and they're hoping that something will get better, as opposed to actually taking a little bit more ownership of the process. And so I want to now switch gears into the areas where we have done even additional work beyond that, which is the concept of this idea of determinism, fatalism, and predestination. So these are key concepts that are actually important as we think about this, and many of you may already be familiar with this, that the concept of determinism, that all aspects of human psychology and action are determined by antecedent conditions in accordance with the laws of psychology and physiology. And then fatalism is the other idea that no matter what we do or think, a particular future course of action is foreordained for us. And then predestination is the idea that God has already saved or damned all souls, and nothing we can do in this life can change that. So you can imagine, depending on where you're coming from and what your approach is, it can impact the way you engage healthcare, the way you manage disease, and the way you actually interact with clinicians. So we started doing work. One of my early work was in 2003, where I was working with Barbara Poe at that time, and Barbara we were both at Medical University of South Carolina, and Barbara was doing work around fatalism and cancer. And I was actually very intrigued by what I was seeing in my clinical encounters and patients, especially my minority population, this idea that it doesn't matter what I do with diabetes is meaningless. You really have no control over it. And if God decides that you're going to live, you live or you die. And at that time, there was no research being done, and there was very limited data to actually help guide the work we're trying to do. So I ended up doing a lot of focus groups, a lot of qualitative work, and we essentially decided to define fatalism in the context of diabetes. And this is the idea that life events are determined by fate, and as such are inevitable, with individuals powerless to change them. And we actually qualified that because from cancer, it was one thing where the end result was essentially fatal. And we actually, from our focus groups and from the work we did, that it was characterized by perceptions of despair, hopelessness, and powerlessness. And that fatalistic beliefs and attitudes can undermine motivation and capacity to practice effective self-care for chronic disease, which would in turn impact both physical and mental health. So we published a series of papers around this. And what we then ended up doing was we developed a 12-item diabetes fatalism scale that has been translated into 7 languages and used in 9 countries, a bunch of studies now, but all of them consistently identify diabetes fatalism as associated with poor diabetes outcomes. And we had 4 constructs in that area, and one of the constructs was religious and spiritual coping. And one of the greatest struggles we had, at least I had, in analyzing the data was I was getting conflicting results. In some cases, we had people who scored very high on the spiritual coping, who had good outcomes, and on the other hand, we had people who scored well and had poor outcomes. And I really couldn't understand why that was the case until I came up with this. I started reading on this concept of submissive and collaborative pattern. coping. And what became very clear was the spiritual, religious and spiritual coping construct, depending on whether it was a submissive or collaborative pattern, actually changed how people interacted, and it affected the scoring. And so since then, now we've developed a short form that excludes the religious and spiritual coping to avoid this problem, because we're recognizing that it's not just as simple as not all spirituality and religion is supportive, and sometimes it's not all negative, and just being able to exclude that and be able to focus on what really happens with fatalism independent of this religious and spiritual coping. So that's we have a paper right now that's under review to finalize that, and that's a 5-item scale that will allow us to actually deploy this in larger surveys and be able to get results very quickly. And then the concept of self-efficacy, it's a very straightforward concept, is that the conviction that one can successfully execute a specific behavior or set of behaviors required to produce an outcome. And in our fatalism scale, we actually have a self-efficacy component. And this is the idea that I'm able to manage this, I have control over this, and I have the agency to actually get things done. And the belief or confidence one has in their capacity to take action, regardless of obstacles, is particularly important in relation to chronic disease. And then as part of the social cognitive theory, the concept is embedded in the idea that environmental, behavioral, and personal factors all interact to influence behavior. So you can imagine from the work of Albert Bandura all the way through today, we all recognize that self-efficacy is really critical, and that the more self-efficacious you are about any chronic disease, self-management, medication adherence, lifestyle, it actually increases your likelihood of having good outcomes. So now I want to kind of lay the ground rule, but here's a lot of where we still see gaps as it relates to population. So I'm going to pose some really questions that we are grappling with, and I would like for this group to really think through and help us think through. So the first is, how do we move from fatalism to self-efficacy? We know that fatalism is consistently associated with poor chronic disease outcomes, and that we know that self-efficacy is associated with improved health outcomes. The challenge is, how do we get patients to move from underlying fatalism to more emphasis on self-efficacy? And how do we do that in the context of faith, in the context of religion and spirituality? How do we get people to just get to a point where there's that shift, that transition? I see this in practice. If I walk into a clinical encounter and the conversation is centered around self-efficacy, it's a lot easier to get good outcomes. Once we focus on fatalism and all the things that will happen and why it's meaningless, you lose traction, and it's very difficult to get people to move into that space. So we need work and strategies and interventions. How do we just move people along that continuum? And where does religion and spirituality play a role? And how do we actually deploy that? The second is, how do we leverage religious and spiritual coping? How do we help patients and healthcare providers to embrace religion and spirituality as determinants of health? How do we actually begin to have conversations about religious and spiritual coping skills in the context of chronic disease? What resources are available in ambulatory and inpatient spaces where the average clinician, whether it's a physician, a nurse practitioner, actually has good grounding on what is a religious and spiritual coping, what's its importance, why do we need it, and how do we deploy it? And then how do we leverage expertise of those in this, largely in this audience, our chaplains, and other religious and spiritual resources in clinical encounters? I think more and more now there's an acceptance that this is important, but it is still not the norm. And when you think about inpatient spaces, I think a lot of work was done primarily in palliative care, end of life, and the question now is, how do we embed this in routine care, chronic disease, and then even in acute care, outpatient settings, where more and more now we should be having this conversation, and what do we actually do to get it along? Then the other area is, what about faith, right? Where does faith fit into all of this? How do we objectively measure faith? For those who come from different faith backgrounds, obviously there's something we're all touching on. We all kind of get a sense of what it is, but how do we actually measure it? And how do we create causal relationships between faith and self-care behaviors for chronic disease? How do we actually begin to actually tap into what are the mechanisms? What are the pathways? How do they actually work? Do they influence psychosocial factors? How do they actually manifest in terms of outcomes? And then can we leverage faith as a strategy to enhance coping and optimize mental and physical health. So these are areas that are really questions that people are exploring right now, but we need more data, we need more pathways, more mechanisms, and more, not just conceptual framing. We need validated pathways. And how do we create conceptual frameworks that can actually be validated, and we can use data to actually prove that these pathways actually work? And then I think the last is, how do we fund and implement some of these programs, right? How do we educate stakeholders at the federal, state, local government, maybe foundations? There are several foundations right now that invest in this area, but this is not the norm. When you go to NIH, when you go to DOD, when you go to all the other funding agencies, how do we actually begin to have conversations about investing in these areas? What about the long-standing principles about separating church and state? How do we get past the idea that this, as we start framing religion and spirituality as a social determinant, as a determinant of health, how do we then begin to actually incorporate that into conversations where it becomes a legitimate and a valid area of research and clinical practice? Who will eventually pay for this? And then how do we conduct research with empathy and tolerance for diverse perspectives? I think we're in a time in our country right now where we're so polarized, and we actually can't have dialogue that allows people from different faith backgrounds, different perspectives to come together and say, let's actually figure out how to make this work. So I think we have a lot of work ahead of us, and I just wanted to allow Dr. Walker to also weigh in terms of some of the things we have seen in the research we've done, especially some of our focus groups with low-income minority populations, and how we actually think religion and spirituality will actually play a key role. And then we'll stop and take questions.
Yeah, so one of the focus groups that we conducted was with food insecure adults with diabetes. And what we were really looking for was for barriers to them doing their self-care for diabetes, which generally involves both diet change and physical activity change, but then also medication adherence, foot care, which is very important for adults with diabetes, and then checking of their blood sugar. And what was very interesting is that we heard, in terms of the barriers, a lot of conversation about food. When we turned the conversation to facilitators of this care, the primary conversation was about religion and spirituality. That was the primary facilitator that was discussed across 3 different groups that we pulled together. We did not bring it out. It was brought out to us. They talked about the importance of prayer in their regular activities, the importance of seeing, because we had so much conversation about food, they talked about seeing, thinking about reading the Bible as spiritual food and daily food, and they made that connection. They also talked about the importance of their faith community. And being part of a community and being given social support. But then what is interesting is that they also, in the conversation, talked about the difficulty of having a chronic disease that requires you change things like your diet when you are within a community that has certain expectations. So again, we really saw that dichotomy between it can be both supportive, or it could be detrimental if people are not able to have a positive coping style with it.
And then the other thing I'll add is we've also done a lot of focus groups with older adults. And as people age, we're beginning to see more and more now an interest in their faith, in religion, in their spirituality, and even without having a terminal illness, just chronic disease in general. There's a lot of conversation about a desire to have that be brought into the conversation, and many physicians and clinicians have been trained historically not to bring that into the conversation. So it creates this awkwardness where a patient is in front of you, they're talking about their faith, they're talking about their religion, they're talking about their spirituality, and then it's really difficult for that physician to actually engage because they're not sure how to do it and whether it's appropriate or not. And I think that's where we need more of these resources. We need to actually create an environment where it becomes normalized, that these are actually part of what people care about, and we should actually have that conversation. So I'll stop here and I'll let the panel take over from here.
Thank you all. Chuck, you want me to jump in, or you want to? Sorry.
Go for it.
You
You got it. Go for it.
So I want to kind of start our response with thinking about their research from two different perspectives. One, thinking about the application to daily chaplaincy practice or spiritual care integration in a hospital. And this is where I think research gets really exciting for chaplains who may read it less often than those of us who are doing it on a daily basis. But what's great about the research this team has done is that it really concretely identifies ways in which chaplains can integrate and address different aspects of daily existence that can really impact health outcomes. So let me be a little more specific about what I mean. So we know that chaplains already provide care when it comes to existential concerns, grief, feelings of abandonment, or any other type of outcomes that are really connected to why we understand what's going on to us and the connections we have. And what these authors have done in a lot of their work is be able to identify, well, let us capture that in the idea of self-efficacy, how I believe what I can do, and this fatalism, like what's bound to happen. And those are two topics that so clearly come up in chaplaincy encounters over and over again, regardless of a diagnosis group, regardless of the setting. If anything, we know that if you're now in an outpatient setting or with somebody who may have a chronic disease, this can be an easy in terms of how important it can be for clinical and health outcomes. So I would say that. And then the other part that they identified in a lot of their work that may be advantageous for us to think about is that these cognitively based behavioral strategies or approaches to really cognitively evoke what patients and family members may be thinking and how that connects to behaviors is a really advantageous strategy for chaplains to lean into. So how do we as chaplains engage with others in which we cognitively and intentionally connect actions, behaviors with what they're saying? And are we doing it intentionally? And are we doing it proactively? And that may be a way in which we can really enhance the care that we provide. And then for the kind of the second part that I wanted to speak to is that in that same vein, spiritual care researchers and chaplaincy researchers have this really fertile ground and opportunity to really explore, what is it, what types of interventions that we do that can help mitigate some of the challenges that come up for those with diabetes or other chronic illnesses. And can we look at those with regards to fatalism and self-efficacy? Are we intentionally connecting our impact, our care, with measures that have been identified as something that are really associated with health outcomes? I know that as a profession, we are getting much better at communicating our impact, much better at communicating the role we play within health systems and health organizations. I think it's really important too that we take the next step in demonstrating the impact of spiritual care on health outcomes and in our research. And just lastly, before I round out my thoughts, I think I had a few challenges that as spiritual care providers really think about how they're invested in outpatient primary care settings, or maybe it's even through telechaplaincy or remote spiritual care. And perhaps even specifically with pediatric patients, I think there's this often kind of default place we fall to in public health where we think if we educate folks more, it'll fix the problems. And I don't know if that's necessarily the best approach for religion and spirituality. There are some things that are just core to people's identities and beliefs that we don't necessarily need to teach them better or teach them another way of looking at it, but help them kind of embrace it, and also know that you can embrace who you are. You can have confidence that if you do this, it can help your body. How do we really get at those root teachings, theological teachings? Maybe it's how we understand our bodies and how that's connected to theological foundations or divine understandings that are really warrant, I think, further exploration. Because a lot of times in public health, we talk about the root causes, right? What's the root cause of food insecurity? What's the root cause of poverty and insufficient housing, right? But when it comes to religion and spirituality, it's not as clear to say that the root cause is believing the wrong thing, and it may be a little more complex and definitely warrants more research. And with that, I'll turn it over to Dr. Rajayi.
Thank you. I just want to acknowledge this was a great presentation and good to hear about the work that you all are doing a little bit further down the line since we've met before. As a person who has studied specifically around diabetes and spiritual distress, I think there's a lot of really notable things within the work that you are presenting here that I think is different than many the perspective that many chaplains have because of our positions within healthcare systems. And I think Kelsey really has described that quite well in terms of grappling with those, the challenges that we have and the opportunities that we have within. And I want to sort of lean into the challenge of religion and spirituality as it relates to like an area, a topic area of research as a place in which it's, you noted it at the end of like, where do you get funding? How do we make sense of this? How do we articulate spirituality and religion as a social determinant of health, as a potentially a structural factor that has an impact alongside some of these other factors? And I think that for chaplains who have spent most of their careers working at the individual level, thinking about this person, their experiences, their family system, to see them outside of that can be challenging. And it takes a little bit of thinking about what is influencing or what has happened before, not just within their family system, but within the structure of their life in wherever they're located and in whatever particular time. And so I guess that's a place that I think that I'd love to continue to have a dialogue with all of you about what that looks like and how do we sort of, what is the framing going to look like? Not just what has it looked like? Because I think the way it has looked has been a little fuzzy, especially once you move further down the line away from religion into spirituality, it just gets fuzzier and fuzzier. But like, how are we going to articulate that? What are those key pieces? I think that looking at how it relates to fatalism and diabetes fatalism and the connections that you've made between that and self-efficacy I wonder how many people have really sat down and thought about how people's religious beliefs actually do change their behaviors in a meaningful way outside of the context of end of life. And what opportunities do we have to sort of expand on that? I think that's what I'm going to pause for now.
Wonderful. Thank you, Kelsey. Thank you, Raji. And let me first of all just kind of give the stage back to you, Dr. Walker Negedi. As you've heard the responses, anything kind of gets sparked in your brain while they're talking, I'll remind everybody else that if you'd like to raise a question, do use that Q&A or the chat, and we'll be able to then incorporate your feedback into the conversation.
Yeah, I'll go and I'll let Rebecca go. I think we have at least for me, I've been grappling with this since probably 1999. I remember my first patient was an African American man who with type 2 diabetes, post amputation. We're having conversations. He said, "Well, God has ordained this. It's my faith, and it is what it is, and I don't see why." And we had a very serious conversation about what do you mean that God has ordained this. We went through faith, belief, and that's when I got really interested in asking the question, what does this really mean? And then as I see more and more patients having this conversation, initially I thought it was a southern issue, in the South, and then when I moved to the Midwest, I've been all over the place now, and it comes up over and over again. So it's real. The question I think what we, as I've heard, is that there is a whole theological basis, a lot of the conceptual framing that lives in the space of philosophy and maybe in other areas that never really crosses into medicine. And how do we actually even get medical students, trainees, to actually begin to understand these issues, and then actually begin to see that because people get frustrated with self-efficacy. Why can't this patient do this? Why can't we just get them to do what they need to get done? And how do we actually begin to get people to understand that, there are certain core beliefs that we have, and those core beliefs actually drive how we act, what we believe, and how we actually function. And maybe it's not about trying to change people's core beliefs, but really leveraging their core beliefs to see if it can actually improve health outcomes. So I think that's one area. The other area that I think that just came to mind as everyone was speaking is the idea that are we designing studies that answer questions that health care providers and health systems actually care about? There are theoretical questions, existential questions, but there are also core clinical questions. So, for example, something as simple as how do you fund programs like this in a primary care setting, outpatient setting? How do you fund it? What is the link? What is the return on investment for someone who's investing in this? What does that really look like? But then more of a research question along the lines of what are the pathways? What actually matters? If I change this, what does it lead to in terms of certain outcomes? But now in the context of health outcomes, blood pressure control, lipid control, diabetes control. And I suspect that these answers already exist. We just have not synthesized the information and really brought it into trials that allow us to then support it. Rebecca?
Yeah, I think while I was listening, one of the really interesting things is this is very similar to the conversation around social determinants of health as a general topic and how that's treated within the healthcare system. And as we have slowly obtained more information to make that connection, to show that food insecurity has this outcome that a physician is trying to change, but they can't because of these other social risk factors that someone is facing. Housing instability has this type of impact on someone, and changing the conversation from, I'm not asking you as a medical student to learn how to address food insecurity. I'm not asking you to find housing for the individual. But as you're having a conversation, to recognize that these factors are influencing what they are and are not able to do, that is then having an impact on what you are asking them to do. So I think that there's actually a lot that has been learned over the course of time of looking at this as a determinant of health outside of the clinical encounter, but having a lot of impact on clinical outcomes that could be used to inform how do we develop these interventions, how do you create, because a lot of what we have found with social risk factors is creating these linkages. So a primary care provider can be having a conversation, realize that there is an influence that they might not know how to address, but that there is a connection that they can now make for those individuals. And then also giving them the information on how do you ask questions that can elicit those responses, and feeling comfortable asking those questions as opposed to feeling like that's not something that they can discuss.
I deeply appreciate this conversation, and the echo that I'm hearing is an echo of conversations I've heard recently on artificial intelligence. And in specific, whether the use of artificial intelligence is used to organize and synthesize past data, or whether artificial intelligence is used in order to synthesize and generate future responses. And it seems to me like one of the challenges for spiritual care is that it has tended to be, it's tended to function within the larger ecosphere as something to make sense of what has happened. So, kind of creating a narrative by which a patient is able to make sense of what has happened to them. And I think what the two of you are encouraging us to think about, and it broadens the perspective of spiritual care, is to say, can spiritual care be a generative influence on people's overall health? Can we have a positive impact, not just on them feeling okay about where they are, but the outcomes of their health as they step into the future? The question I have with Kelsey's comment is, to what extent are these variables of religion, spirituality, fatalism, to what extent are they malleable? And to what extent are we dealing with a given that we simply have to be able to explain what the impacts are? What have you seen in terms of the ability to use religion, spirituality as a positive impact on future behavior?
Are you asking me?
Any one of you.
Okay, because I think that's kind of what in as much as I made a statement, I think that was kind of one of the questions I had. I said it very differently, but I'm on the same page with you, Chuck. And I would just add to that for whomever has a thought, because I don't know that I know. I don't know. And I think in as much as we absolutely need more research that looks at these constructs and looks at religion and spirituality's role and impact on health outcomes, and more funding, I think, I don't know, part of me is like, we also need to be prepared what the implications of added attention on those constructs could be in terms of how systems change and adapt, and what that means for healthcare providers' feelings of engaging those topics beyond what they do currently. And anyway, it brings up a lot of questions, but I'll leave it at that.
I think it ties to my sort of follow-up to what Dr. Getty and Dr. Walker were saying, and sort of connects these points as well. I think one of the things that is difficult is that, speaking for the chaplaincy side of things, not the medicine side of things. So I think that these are two worlds that live in completely different universes. They do have connections and ways to travel between, but there's this very clear sense that, like, medicine lives here, public health lives in its own little space, and then chaplaincy is in its own little space. And historically, the way chaplaincy are trained, going back to that one-on-one sort of like relationship, I don't know. I think one of the challenges is that we don't have a language that says when a person is using this type of language, or if a person is expressing this type of thing, this is an experience of distress. This is an experience or an indicator of potential something, fatalism, that we could address, that we can actually provide some form of interaction with. But that language has not been taught to chaplains historically. And so they don't have that language. And on top of that, while we have come a long way in utilizing evidence-based practices, or seeing that as an important component of the work that we do, it is relatively new to some folks still. It is still very much in its infancy in training programs. And that disconnect makes some of this other work very difficult, because how do you then connect like the work that you're doing in a physician's visit, or like working with the patient and their family when they're identifying these concepts and these constructs? How does a chaplain actually respond? Do they know how to do that? And I think that there's a big question on, I think they could, but I think there's an opportunity there, but it's going to require training. It's going to require some new language and new ways of thinking that we haven't yet really done. And we need a crosswalk to be able to say these things are connected.
Dr. Walker, Dr. Rigetti, let me phrase it a little differently as well. I don't think you would have published on religious fatalism if you thought that it was a fait accompli and there was nothing you could do about it. And so I'm wondering what you find when you begin to take apart this construct that we as chaplains are not seeing as a potentially positive factor.
Yeah, so I think originally when we designed, at least when I designed the fatalism scale, I thought it was a trait, and it was just how you were and how you developed. And when we've actually tested it in models, longitudinal models over time, we find that it's actually more of a state. Right. And what that means is that depending on where you're coming from, other factors around you, your experiences, that things actually could shift. And so then, we are now actually asking the question, what types of intervention would actually begin to move people in the right direction? And I think that's where chaplaincy comes in. First of all, one, understanding the individual's base religion and spirituality, where they're coming from, right? What has shaped that experience, some of those beliefs, right? Some of those grounding. And then the question becomes, how much of that is actually grounded in just your core belief, and how much of that is learned over time, where you've adapted, you've accepted, you've seen it. So for example, I've had patients who say, everyone I know, and when I started this work early on in the, early 2000s, everyone I know has had an amputation. Everyone I know who's had diabetes is on dialysis. So it is what it is. And then you start asking the question, is this truly everyone you know, or are those people you remember? Right? Because we have a tendency to remember the things that are actually major, right? And it turns out that when you actually talk to people, and we started using peers to talk to people who have actually successfully managed their diabetes and said, look, I had it, I developed this, but I'm actually better now. We could actually get people to start thinking differently. It shifted that general sense. And so I wonder if some of the conversation around how do we, it might be more along, I think the short answer is, I think these things are mutable, but it's not as simple. It's going to require grounding, understanding where people are coming from and what are some of those drivers. And that's where the pathways and mechanisms become important. What are the different pathways that is actually with what's happening, what's operating behind the scenes, and then which levers can we push or pull to get the kind of results that we actually want. And I think an important part of this is this idea of a crosswalk, the crosswalk between chaplaincy and the medical field. And we use overlapping language, but sometimes I think having some kind of crosswalk will actually help, so that when individuals are having conversations, you can say, this is really distress, and we have measures of distress. This is self-efficacy, low self-efficacy, we have measures. And then we can then say, we know this leads to this outcome. So if we fix this on this end, we potentially can actually have better outcomes. Rebecca?
Yeah, go ahead, Kelsey.
Sorry, I think there's something, and I'm wondering that if you all have seen it in your work, is this idea of like the God locus of control, like where we see how a person sees the locus of control, God, and their being, if that, how that's related to fatalism and self-efficacy, because I would assume that could play a huge role in all of this.
Yeah, so what we've actually done is we very early on in the work, we did a lot of studies looking at is fatalism a real construct or is it a surrogate for something else? And we actually tested, one of the areas we looked at was locus of control, and they're independent. So typically, if they were highly correlated, then you're measuring the same construct, right? We find that when you actually look at the measures at different studies over time, the constructs are different. I think they are there is some level of locus of control affecting how people view things. But even I would actually argue that even with locus of control as we know it, right, that the same individual, you could actually tap into their God locus of control and it becomes empowering in terms of, it builds strength, it builds fortitude. Whereas for others, it may actually be the idea that, well, it is what it is. And if God is not going to do something for me, then I'm stuck. Right. And I think how we frame, that's why I was alluding to how we frame this conversation. And the more we understand some of these pathways and mechanisms now, the more you can actually have a framing of the same conversation, but leverage it as a way to actually get the results that will improve health.
Yeah, absolutely. And I do think that it's interesting when you describe that the historically chaplaincy focuses on the individual and thinking about it at a population level is a little bit different. It's very similar when you think about the one-on-one medical care to public health. And what we're finding is there is the idea that you can only do one or the other is actually the separation. That's what makes it feel like it's so difficult to do both. But the recognition is that the individual provider's interaction is indeed with one person. However, they're basing that on evidence that's been developed over time, on language that has been developed across multiple populations, and understanding how those differ, and understanding how you can use experiences that were developed at a population level in this encounter that you have at a one-on-one level. So it's not negating the importance of the one-on-one. It's actually adding to it.
I would also just jump into there that maybe we aren't necessarily doing population health, but we are doing primary prevention. We are trying to primary and secondary prevention in terms of helping people stay well and stay healthy, but also potentially manage or reduce their risk of developing certain conditions if they're on the edge. And I think that's a new way of thinking for chaplains to imagine helping to be a part of keeping them out of the hospital versus just meeting them when they're in it. And so even that slight change of like, it's not always about just the population health, but it has a population health potential impact on population health. But I think this is, again, like an opportunity to think about how are we educating, how are we talking about this, and how can we potentially do better?
I love our last comment here that precision medicine, precision chaplaincy, and population health can all be mutually reinforcing. I can say amen to that, and I'm guessing that the rest of us can as well.
Chuck, I'm going to jump in here. My camera's not turning back on. We're at 1 o'clock. And yeah, it feels like a couple of logs got put on the fire here. So I'm not the one who, but I know we got to end it. And I just want to say a huge thanks to you, Chuck, Kelsey, Gila, Rebecca, Leonard, thanks so much for the gifts of your time, your scholarship, and how it contributes to how we make sense of this work and move forward toward caring and healing the people that we get to serve every day. So friends, thanks for being with us. Hope to see you again for our next webinar. Please check this out on YouTube if you want to watch it again. And thanks to everybody. Happy fall to you. Blessed be.
Thanks.
Thank you.
Bye-bye.